You know, it's really nice to be back. I think this is a wonderful meeting, and I'd like to thank the sponsors for, despite my having spoken before, asking me back. But when they did that, they gave me sort of an interesting sort of charge, which was to talk about personalized therapy. Usually when people are up here talking about something like this, it's, you know, what's new? And the problem is with personalized therapy in colorectal cancer, I'm going to talk mostly about debunking things and things that are not necessarily so new. Now, however, there is a bonus at the end, if the chair will allow me, because there are some new things in colorectal cancer. I did get permission to put a couple extra slides in. So this is not just on personalized therapy, and hopefully it made it to your digital whatevers that you get instead of books. So most people up here, believe it or not, let me give you a dirty little secret. Most of the talks that you have seen for any talk, whether it's at ASCO or whether it's for the Nobel Prize or whether it's NOCR, are not purpose written, and that you use slides from other places. And so in some ways, actually, I appreciate being able to actually have to sit down and think about personalized therapy and going back. But personalized therapy means, you know, basically choosing the right treatment. And it's been talked about, and we actually have breast cancer envy, because I was here earlier. I flew in from Los Angeles early this morning, and listening to all the great subtypes that they have in breast cancer. And as clinical oncologists, you know much more about this than I do. I don't treat breast cancer. Lung cancer is also going down that pathway. And unfortunately, we are lagging in colorectal cancer. You're all familiar with biomarkers. Oh, that's right, I'm supposed to use the mouse. Is there a mouse? Okay, how about this? I'll use this. So a biomarker, yeah, it doesn't seem to be working. So, but anyway, a biomarker is something that you're using to try to either be predictive or prognostic. And I want to make certain that everyone understands the difference between these two, because there are a lot, actually there are misspellings too, but there are a lot of markers that are predictive, but they're not anywhere nearly as many that are prognostic. And predictive markers are useful, but they're not as useful, in particularly in how we treat our patients. And in colorectal cancer, there are actually a goodly number of predictive markers that are for sale that you can order, but there are only a few that are prognostic and telling you what to do with your patients. So this is the test, of course, that I really do want to order, which is your DNA test shows that you're predisposed to sue doctors. This patient, however, I send across town to USC. So but Heinz doesn't mind. But anyway, so the problem with doing a study to show whether or not a predictive marker makes a difference is that it is really difficult, it takes a huge amount of patience, and it's really expensive. And people don't like to fund that. The other problem is that, remember, a lot of our studies are funded by the pharmaceutical companies, because they're the ones who have the good drugs, and I work closely with them, so I can't say that that's wrong. But on the other hand, sometimes you may not want to exclude people. The downside is that anyone who's had a negative trial wishes that they were able to have better predictive markers if you have a drug that you know has some activity. So basically, in order to show that something is actually not just prognostic but predictive, you have to have two different strategies. One of which and basically with a dual randomization. So in order to talk about markers, really what you need to do is you need to understand more about the biology of colorectal cancer. And I'd posit, as I said, that we do not understand as much about the biology of colorectal cancer as we do about breast cancer or lung cancer or maybe even gastrointestinal stromal tumors. But unfortunately, we've been really sort of falling far behind. So really, there are only a few ways to slice and dice colorectal cancer right now. The oldest way is between patients that have abnormal DNA mismatch repair or microsatellite instability, which is another term for that. And what happens is that these people have alterations in their proofreading genes, and it's a set of, basically, of genes that encode for a set of proteins that have to do with making certain that errors do not continue into the DNA. And this is about 15% of colorectal cancer patients. You're familiar with this. They tend to be right-sided. They tend to be women. They tend to be older. They actually look different. They tend to be more poorly differentiated. They also tend to do better. Most of these are sporadic, and they have a BRAF mutation. However, a number of these are Lynch syndrome or HNPCC. Now, the other 85% clearly is not the whole gamut. And instead, it's kind of a garbage bag where we've thrown everyone else. And sometimes this is called chromosomal instability, or these are MSS, microsatellite stability. They tend to have APC mutation. We'll talk in just a little bit about some of the subgroups that have been peeled out of this. So this is actually just from about a month and a half old, or 2 months, a month and a half old, from GI ASCO. So I apologize about, we can fuss about the ASCO website. And unfortunately, I couldn't get the slides yet from Joseph Tabanero. But basically doing the things that were done and I saw presented 10, 15 years ago, we're finally beginning to get some subgroups with colon cancer. I don't expect you to know these. He divided these up into 3 groups, A, B, and C. And these you can tell from the heat map. These are clearly different and from this hierarchical analysis clearly show up as different. What our job as translational researchers is to see how does this translate clinically. Another group at the same time, this looks very similar to the chart. I can't remember who the speaker was showing about breast cancer. Actually, the group from Duke, Dr. Uranis, was also able to show 6 different molecular subtypes. And I think this is really the future. We're not going to be treating all of colorectal cancer the same way, but right now we do. This is actually another a very important data set, and there are a number of different tumor types that are being completely deep sequenced. And this is the Cancer Genome Atlas Network, and a number of these have been published. And this was published in Nature last year. And what you can see is that there's certain very strong signals. And what they did is they divided these up, because this is the way the tumors divided up. I don't know if you can see this or not, but between those that were hypermutable, that same MSI group, as opposed to those that had MS stable. And you can see that some things like Wnt signaling and TGF-beta signaling were very, very common. And if you look further down, you see the targets for some of our drugs. PI3 kinase signaling was also a separate subgroup and seemed to be important. And some of these are through like EGFR. And this is another way of looking at it. But I think this really, truly is the future. It's just not the present. So what are the biomarkers we have now? And the one that we really have most is Tnm staging. And this started by Cuthbert Dukes. I actually went back and found one of his original papers, which is not so easy, from 1932 in the Journal of Pathology and Bacteriology. And what he was a pathologist with a great name, Cuthbert. And he was in the UK. And he was able to predict which patients were going to have inoperable disease and which patients with rectal cancer. And this actually became the genesis of AJCC staging. This is all that we have. These are prognostic markers, but not necessarily, I would say, predictive markers. And this shows that Tnm staging does work, though you see 3A is kind of out of whack and up there. But the higher the stage, the worse patients do. But the problem is that this is all that we have. Once again, it's not prognostic. Unless you have a group that does so incredibly well, you don't need to do anything else. That's really all that, and that's what we do with stage 1 colon cancers. That's all that you can do. Now, there's some other biomarkers I'm going to talk about just off the cuff because I only have 25 minutes. There's molecular pathology. I'm not really going to talk about circulating tumor cells. You can buy the machine. You might be able to charge for it. It's been really difficult to show whether it makes any difference in how we treat our patients. We'll talk about some mutations and also about gene expression profiles that are commercially available. Let me try that one again. Okay, so where would biomarkers be most useful in colorectal cancer? Well, adjuvant, of course, because we only want to treat those who are going to benefit. Remember, the majority of patients are cured by the surgeon. I hate to say that, but it's true. And so, but on the other hand, there's clearly a subgroup who benefit, and there's also a subgroup, 2 subgroups who don't benefit from our adjuvant treatment. Those who are cured by the surgeons, and those who are going to relapse no matter what we do. But it'd be really nice to figure those out, so we only treat perhaps at 20 or 30% of people at most who are going to benefit. And then with metastatic disease, we now have a whole palette of agents. The question is which ones to use and when. We just tend to kind of throw most of them at the wall and see which ones stick. So in stage 2 colon cancer is a place where biomarkers have been useful. Now, the vast majority of them are cured with surgery. It's been difficult to show that adjuvant chemotherapy really makes a difference. Probably very small percentage difference, breast cancer differences, not like in stage 3 colon cancer. And so the question is that who of these people with stage 2 colon cancer should get additional chemotherapy? How many people here in the audience, we won't do this through the iPads, give adjuvant therapy for stage 2 colon cancer patients? Okay, I can't say we'll talk about whether it's right or wrong. How many patients give chemotherapy for high-risk stage 2 colon cancer patients? Okay, but the data is weak, and so we should talk about it. And it's none of it is directly none of it is sort of set in stone. I want to thank the IT people here for rescuing this slide, which somehow was lost from going from Mac to PC, and actually from old PowerPoint to new PowerPoint. But what you can see is that in stage 3. So in stage 3 colon cancer, you get a big benefit, a big delta. But in stage 2, I think these curves got stretched a little bit when we were rescuing it. You get a small benefit, but it's probably statistically significant. It's not quite so good. We were playing this morning with this. So there are a number of histologic factors you can use, and these would be biomarkers. Bigger tumors, worse tumors, perforating tumors. And these have been, not enough lymph nodes, these have been looked at to see maybe that they do worse. And this is from the Mosaic trial, which was FOLFOX versus 5FU, and you can see the high-risk stage 2 patients do worse. So there are other ways to look at this. You can look at maybe not just IHC, but you can do various molecular techniques to try to find whether lymph nodes are positive or not. No one knows what to do with it. Now, this is the crux of it, which is to say that patients with MSI or deficient DNA mismatch repair tend to do well, better stage for stage. And what Dan Sargent did is, with others, looking at these huge groups of people who were treated with 5FU, and what they can say is that people who had DNA mismatch repair, which is the top line, I'm sorry, it's hard for me to see, I have my computer glasses on, actually did worse when you gave them 5FU. Okay, so that's a bad thing when we make people worse. We make them do as poorly as patients who have MSS tumors. MSS tumors do a little bit better. MSI tumors do worse. Now, there are a number of different genomic tests that are marketed. How many people here have used any of the marketed genomic tests to decide on whether to treat or not? Okay, there's something else going on here. Well, I can keep talking, but basically, unfortunately, none of those have been shown to be predictive as to whether or not you should give chemotherapy or not. They are prognostic, but they are not predictive. And so they've all been negative. The trials have been negative so far when they've looked at actually prediction. So let's talk about in metastatic disease. We have cytotoxics, we have anti-EGFR antibodies, we have anti-VEGF pathway agents. So for fluoropyrimidines, there are places people will look and see whether you look at TS or DPD, and TS is the target for fluoropyrimidines. A number of sites, including across town from us, are really interested in this, but no one has ever shown that it makes a difference in choosing whether or not to use 5FU. DPD deficiency is rare. No one really tests for it unless someone, basically their mouth falls out and they get neutropenic after a fluoropyrimidine. And it's still not that useful because it's not either good or bad. It tends to be a spectrum. For irinotecan, in the label, it says that we should test for UGT1A1 star 28. How many people do that before you give someone? Really? Okay. And so, unfortunately, the trials that were done said that because it's in the label, said that, that it actually correlated with diarrhea. However, further trials actually were unable to actually corroborate that. Instead, it correlates with neutropenia, and it doesn't tell you what dose to give. ERCC1 for oxaliplatin is also of unproven efficacy. So what about anti-EGFR agents? Well, we're going to check into the Hotel KRAS. I just love this picture. This is actually in Romania. There's a chain of Hotel KRASs, and so this is a very simplified version. You've seen this many times with EGFR as a member of the HER family. It hetero and homodimerizes. And of course, RAS is downstream. So mutant RAS is found in about 40% of colorectal cancer patients. So a mutation probably would not be a good thing if you're blocking upstream. Unfortunately, this is really what it looks like. So it's not as simple, but we love these simple cartoons because I can't even see this on my computer, much less on the screen. So Rafi Amato, who when he left UCLA, I got to pick up all his colon patients. When he went to Amgen, showed this is a reanalysis of a panitumumab trial, and you can see the patients who have wild-type KRAS benefit, and those who have mutant KRAS don't. What about G13D? How many people here look for G13D mutations? That's found in about 20% of that 40%. And there's some data out of, actually this is from Leuven, from Sabine Tejpar and Eric van Cutsum's group in Belgium, saying that maybe G13D mutations don't have the same badness as the rest of the KRAS. However, we've been unable to, when we look at all the panitumumab data, actually, if anything, they do a little bit worse. So I don't think that that really is ready for prime time yet. What about looking downstream? So in our simplified cartoon that didn't look like the subway map, so you have KRAS, and there are also BRAF mutations. Now, BRAF mutations are relatively common in colon cancer, not as common as in melanoma. It is the same V600E mutation that's found in melanoma. It is a really bad thing to have. These patients do terrible. So when you look earlier, like stage 2, it could be as high as 20%. When you're with first-line metastatic disease, it's lower. It's probably about 10%. In Salvage, it's 5%. And the reason is, and you've probably had some of these patients, they die really quickly. And so we know this is a bad prognostic factor. The question is it a predictive factor? The other thing that's a little bit interesting as a sidebar, we actually were part of a group that looked at vemurafenib, or PLX4032. And even though there was a very high response rate in melanoma, there was a 5% response rate in colon cancer, showing that the same mutation in the different setting may be very different. And so we'll talk about that perhaps when we talk about KRAS. So the question is that there were a number of groups in Italy that said, looked at their patients who had cetuximab or panitumumab and said they did poorly. And this actually made it into the hallowed NCCN guidelines, okay, into scripture. And so unfortunately, there was no one had looked at any randomized trials. So while obviously the NCCN is not infallible, so this was actually a reanalysis of the Crystal data, which was a first-line trial, looking at FOLFIRI plus or minus cetuximab. And what you can see, I don't know if you can see it from here, but just to tell you what happened, was that yes, they did poorly, but they seemed to benefit from cetuximab. Both arms did poorly, but they seemed to benefit. So that should not be used as a reason not to give an anti-EGFR. I think this will be very interesting. There are other markers, ligands, amphoregulin, epiregulin. Copy number has sort of fallen out, but the Italians like that. And I think you'll see some more data within the next year that I've at least seen some preliminary stuff. There's some very interesting data that might help us narrow down things and do a little bit better. So this is a really quick thing. So for anti-VEGF agents, which is a lot of what we do, there are no good biomarkers. Okay, zero, zippo, which is good if you're selling the drug because you get to treat everyone, but it's not so good because we know that only a minority of these patients are helped. People have looked at VEGF-A levels, people have looked at second-generation VEGF-A levels, they've looked at neuropilin, which is a co-receptor for the VEGF receptors, but none of these have shaken out, at least in colon cancer. Okay, let me try again. What about molecular profiling? How many people here order KRAS or Foundation panels on their colon cancer patients? Okay. You know, these are basically panels of multiple targets. I don't think that, all they do is make my life miserable because the patient comes in with a stack this big. They've already had their tumor sequenced. This is Los Angeles maybe, but they have the KRAS or Foundation profile, and it tells me the patient has a V600E mutation. I should give them sorafenib. Well, I know that sorafenib is a cruddy RAF inhibitor. I also know that a good RAF inhibitor doesn't work in colon cancer. So that's the problem, that I don't think you can extrapolate necessarily. The biology may not be exactly the same from one tumor to the other. And you have to do trials looking at specifically, I think, in your tumor. So I think these are interesting, and they're certainly a good business model, but I'm not certain how helpful these are. Sequencing gives you just huge stacks of data that we don't necessarily know how to interpret, and I certainly can't talk about in 25 minutes. More interesting, perhaps, are explants. There are a number of companies that will take your fresh tumor and put them into nude mice, immunodeficient mice, and grow them, and you can have your own little trials on this. This is only for the 1%. Okay, because it's not cheap, but it's coming down in price. Every year it keeps coming down. We're talking a few thousand, $5,000. To get it put in, and then for each basically experiment that you do. The problem is it takes a number of months to kick in, so this is really for salvage. I can't say it's wrong. I think it's actually very interesting, but I don't think that's ready for prime time yet. As I said, there's no evidence of clinical benefit, and I just wish the KRAS or Foundation would pay me for the time going over the stuff. So we are on the verge of truly personalized therapy, but we're just not there yet. We still envy our breast cancer and lung cancer, well, maybe not the lung cancer colleagues, their patients still don't do that well, but the breast cancer colleagues, sorry, Corey, okay, we envy them too. But we need to know that pretty soon we're going to be able to do it, and we shouldn't be I don't think we should be ordering them right now. So So then, if I have a few minutes, I put this in because it's this cheesy stuff because it's Las Vegas, guys. And so I figured it reminded me of one of the slot machines. So this is a no-cost bonus. So whatever you paid to come here, okay, you get this for free because there is some data that you probably should know about, but it has nothing to do with personalized therapy because there are no markers for this. So we've actually had sort of a surprising renaissance in VEGF therapies in colon cancer. Now, how much it helps patients is a different discussion. This is another one of these simple cartoons, and you can either, VEGF-A is probably the most important, but there are a number of ways to block VEGF. Bevacizumab you're most familiar with, which is a monoclonal antibody against VEGF-A. There are artificial antibodies like a Flivver Cept we'll talk about. There are ways that you can block either through small molecules or antibodies that you can block. This is back what I call the golden age of colorectal cancer therapeutics, when we used to run from hall at ASCO to hall at ASCO because the standard of care was changing so rapidly that trials were obsolete by the time that, at least the control arm was obsolete by the time you finished the trial. That has not been the case recently. But this is with bevacizumab obsolete, the SALTS regimen, or IFL, which is probably the worst way to give 5-FU and irinotecan. But it is actually the worst way. It's the most toxic way and least effective. But that's what phase 1 brought out in the US. But what about angiogenesis inhibitors after first line? So I don't have time really to talk about that, but most people in the United States use bevacizumab in first-line therapy in patients who are candidates for that. How many people here use bevacizumab first line? Okay, I figured everyone does. In Europe, actually, cetuximab is also commonly used, but not as common in the United States. But what about after second line? Is it more like trastuzumab, or is it more like a cytotoxic that you don't want to give it again? And there are at least 3 drugs now in this space, and at least overlapping in this space. So remember, there was the ECOG 3200 trial from Bruce Giantonio, which showed in a group of patients that don't exist anymore, people who had failed 5-FU, who didn't get bevacizumab first line, that if they got FOLFOX second line, it was better than FOLFOX, actually FOLFOX alone. And actually bevacizumab alone actually probably had some activity. And so remember, bevacizumab was approved for first or second line therapy. There were a lot of people parsing this kind of in a Clintonian fashion. Does or mean and or does or mean? And there are actually people who are part of our network who refused to give bevacizumab second line because they were worried that the Medicare police were going to come by. They had been audited once, and so they would send them to us because we, hey, sock it to UC. No, I probably wouldn't go to jail, I hope. So people were going to say, did it mean that you could give it second line if they had it first line? Because the label was first or second line on the basis of those trials. So what there was before, there was something called the Bright Registry, which was marketing genius. And what they did is they looked at people who had bevacizumab second line, who had failed or bevacizumab beyond progression. And they did better than people who didn't. But as I was teaching at Journal Club earlier this week, of course, people who do better are more likely to get second and third and fourth line therapies. So registries are hypothesis generating, but should not actually tell us what to do. So there was a trial from the German cooperative group that was co-opted by Roche, and this was the ML18147 trial, or TML, not TMI, but TML, treatment in multiple lines trial, randomized trial. People had failed a bevacizumab-containing regimen, and lo and behold, there was a modest improvement in overall survival, as well as probably a reasonable improvement in progression-free survival. So I think those of you like us who are giving bevacizumab second line, there are a couple of things. One, it was probably worth doing. And two, this is actually from Alan Vanook at UCSF, who was a discussant at this at ASCO, is really, really be careful when you look at registries. They're great for marketing. They're not necessarily so good. But look at the difference in data. People in Bright had this difference. People in TML in real life had that difference. What about a Flivver Cept? I have 33 seconds. The Flivver Cept is an artificial antibody. They took receptors from VEGF receptor 1 and VEGF receptor 2 parts of it, fused it to an FC domain, probably the slowest developed drug of all time. Okay, but now it is finally approved. There was a randomized trial called Velour, which was a Flivver Cept plus or minus, FOLFIRI plus or minus a Flivver Cept. And these patients could have had bevacizumab or not because it was mostly done in Europe. And what you can see is there's a small benefit. Looks very similar to bevacizumab. When they looked, I'm going to do this real quickly because it's flashing. When you look at whether it has prior bevacizumab or no prior bevacizumab, it didn't seem to matter. So this is another way of saying that probably that bevacizumab or a Flivver Cept after bevacizumab makes sense, that there's a small benefit in doing that. And I'll get to the finish up on the last one before the Dr. Ilsen kills me. So is a Flivver Cept better than bevacizumab second line? We don't know. It certainly was priced higher, and that was kind of a debacle. But the cost has been cut. I saw something where this was listed as one of the 5 worst drug launches of all time, but hopefully the cost now is more reasonable. There are differences in toxicity, but once again, it's hard to tell. It's never compared to head-to-head. And what about EGFR antibodies? There's a trial, this is a plug, that I ran called Spirit, which looked second line, that looked very similar between the two, and we'll have some data at ASCO and first line. Finish up, small molecule TKIs. They've really been a bust in colon cancer, the graveyard of VEGF receptor TKIs. I've run 2 of these trials, and thousands of patients, almost 7,000 patients now, have been on trials that were negative chemo plus VEGF receptor inhibitors. So what about Salvage? So the regorafenib is sorafenib with a fluorine rather than a hydrogen. It was made that way so that Bayer didn't have to pay Onyx royalties, but they still have to. But it's probably very similar. The correct trial, which was presented and published by Axel Grothe, looked at patients that we see who failed everything. Colon cancer patients tend to live longer. And what they showed is that if you make the graph look good enough by stretching it out, these are in days, that you can see a significant difference in overall survival. That then if you go to progression-free survival, there is a difference. And probably this is a biomarker crying out because there's a subgroup that probably do benefit. There are no responses with this. So to finish up, that we have now 3 drugs in the anti-VEGF space. They sort of segmented themselves with bevacizumab in first or second line. We don't know whether it makes any difference further than that. Flivver Cept is in the second line space, and regorafenib, which has toxicity very similar to sorafenib, is also in the salvage space. But we still don't know how to pick those patients who are going to benefit. And thank you for letting me go over. I appreciate your attention. Questions?